Morning.
Okay, I'm just going to get started while things are being distributed. You guys can continue to hand your stuff out if you wish, but I want to get started. In part because, like everybody else, I looked at the weather forecast for this weekend. Who knows if we're going to have class Monday or not. Doesn't sound extremely likely, but I don't know. So I haven't figured out exactly how to deal with that yet. Obviously, I can post notes and stuff, but some of the material is so it's so important and not maybe as obvious as some of the other material we've already had. So I'd like to give lectures actually for this thing. And speaking of the other material, the tests are graded. I just need to put the scores in. It's kind of an interesting distribution. So the average was 80%. Okay, but there's like 5 people got 100%. So the spread is a lot. So we'll see. Typically, the average of my exams are about 83 or so a little lower than usual. So hopefully we can bring that up some. All right, vasopressin, everybody's favorite hormone, right? Decreased osmolality does what to vasopressin?
Increase. Wait, decrease osmolality.
What stimulates vasopressin secretion? What does vasopressin do?
Retains water.
It's involved in water conservation, right? So you increase osmolality.
Decrease vasopressin.
You increase osmolality, the blood is essentially thicker and full of stuff, which means it needs more water, right? So increased osmolality causes vasopressin secretion. And if you guys remember, vasopressin itself binds vasopressin receptors, which I'm going to talk about now, and among other things, stimulates the insertion of pores, water pores, in like the collecting ducts of the tubular system of the nephron. Okay. So in terms of vasopressin receptors, which are targets of, as we'll see, vasopressin analogs, which do get used clinically. The vasopressin receptors are G-protein coupled receptors. There's 3 types: V1A, B, and V2. V1A and V1B receptors typically coupled to GQ, although there's a little bit of promiscuity in some tissues. But but they typically couple to GQ and stimulate the opening of the calcium channel, and they can also activate eicosanoid synthesis. So synthesis is stuff like prostaglandins that are involved in inflammation. V2 receptors coupled to GS, and as we'll see in just a minute, V1 receptor activation and V2 receptor activation cause much different physiological changes, and you're going to need to know to be able to differentiate between the activation of V1 versus V2. Okay, V1 is the most widely expressed vasopressin receptor. It's found in vascular smooth muscle and also a lot of other tissues, including in the brain, so in the CNS, where vasopressin is used as a neurotransmitter as well as its hormone functions. Okay, V1B is found in the anterior pituitary, also in the CNS, pancreas, and the adrenal medulla. So, among other things, what it's doing in the anterior pituitary is it's working along with CRF to cause the release of adrenocorticotropin hormone. So, vasopressin will be released in response to stress. Okay, V2 is the one, when you think of vasopressin 2 receptor, you want to think of the kidney, essentially. So it's mainly found in the cells of the renal collecting duct, and also on the thick ascending limb, and it is in some vascular endothelial cells as well. Excuse me. Okay, so with V1 activation, of course, V1 receptor mainly couples to GQ and is also associated with that calcium channel. And when V1 receptor is activated, you're going to get increased intracellular calcium. So remember, I just said this receptor is found, among other places, on vascular smooth muscle, right? So it's going to cause the contraction of vascular smooth muscle. It can also cause contraction of mesangial cells in the glomerulus. And again, you get prostaglandin synthesis with V1A activation. So when you're thinking about the water conservation aspects of vasopressin, when you think V1 activation, you're thinking, you're tightening up the blood vessels and helping conserve water that way. The vasopressor actions of vasopressin are really the V1 mediated. Okay, this slide then just shows V1 receptor activation. So, and hopefully you can see all this. So up here we, Up here we got arginine vasopressin, AVP, also known as, what else? Antidiuretic hormone, if you want to, of course, remember that, because a lot of times I believe clinically it still gets called antidiuretic hormone. Okay, so vasopressin binds these V1 receptors in cell membranes. Largely, we're talking vascular smooth muscle, those type of cells, right? And activates, among other things, phospholipase C activity, inositol phosphate activity, and ultimately what you're going to do is you're going to get the release of intracellular calcium stores, right? Which, among other things, is then going to help drive, importantly, vasoconstriction, okay? And you get some other actions as well. But the really big thing in terms of its vasopressor actions are, of course, vasoconstriction. Okay, V2 activation results in V2 receptor couplers to GS, so when V2 receptor is activated, you're going to get an increase in cyclic AMP, second messenger signaling, and you really want to think the V2 receptor, you're thinking of actions in the kidney, where we're involved in reabsorbing water, right? So when V2 receptor is activated, you get the insertion of water channel containing vesicles in the collecting duct membranes, and these vesicles contain these functional water channels called aquaporin 2. So those channels, this water will go right through the channel and be reabsorbed into the blood from the tubule system. Okay, it also is going to affect urea permeability in the renal collecting duct, which is involved in helping maximize urine concentration. When I say urine concentration, that means the concentration of urine and pulling the water out of it. Okay. It also, you can stimulate sodium transport in the renal collecting duct and thick ascending limb. So you're going to be also stimulating the reabsorption of sodium, which is going to help, among other things. Of course, you're going to affect osmolality a little bit, but among other things, you're going to increase the amount of fluid in the body, right? Because sodium is the big factor in fluid retention. Okay, so this slide shows V2 receptor activation. So there we have antidiuretic hormone binding the V2 receptor that's in the membrane, collecting duct membrane, kidney cells, right? You get stimulation of AMP, second messenger signaling, because it couples to GS proteins. Among other things, you get increased protein kinase A activity. Series of steps occur that I'm not going to have you memorize, but you do need to know then that what this is going to stimulate is the insertion of these water pores in the membrane, in the apical membrane. So, and then we're going to help. So here's going to be the urine, right? We're going to pull the water's going to come out of the urine and be put back into the blood by V2 receptor activation. So this is just another way to look at it. So blood, urine. So we've got the water coming from the urine side. So V2 receptor's been activated. These pores have been put in, right? The urine side. The water's going to come this direction. Okay, from this is aquaporin 2, but then it's going to get back into the blood. Okay, that makes sense. hopefully straightforward enough. This slide summarizes the effect of V2 receptor activation on water reabsorption in the kidney. The big thing is, here on the left-hand side we have antidiuretic hormone present. On the right side, it's when antidiuretic hormone is absent. So as you can see, and this is supposed to be the tubule system, right? The nephron right in there. Hopefully you can see that, it makes sense. But here you see it at the collecting duct, where drawing the square around this, you get water reabsorption going on. Also, you can stimulate some sodium reabsorption as well. Now, and get some urea movement. And so this slide just shows what happens when it's not there. You don't get that extra water reabsorption. Okay, in terms of drugs for the vasopressin system, I've left this real simplistic level. The current agents that affect vasopressin that are available are all analogs of vasopressin. Okay, so just different essentially synthetic forms of vasopressin. They're going to increase or decrease the activation of V1 and V2. So typically, of course, when they're acting like vasopressin, they're going to stimulate these receptors. And some analogs act as antagonists and can antagonize the system. So in terms of clinical use, you either enhance or decrease the effects of vasopressin, right? And that was pretty simple. Okay, so in terms of pharmacological agents on vasopressin actions, there are some you should be aware of. Drugs that increase the antidiuretic response to vasopressin include NSAIDs, so non-steroidal anti-inflammatory agents. Also carbamazepine and chlorpropamide can. So what do you guys know about NSAIDs? Much? You covered them?
A little bit.
Mostly they're clinical. You know what they do though? They can alter kidney function quite a bit, right? So so you need to be aware of that. Okay, in drugs that inhibit vasopressin antidiuretic actions include lithium and democlocycline, so an antibiotic. So essentially, somebody's taken lots of these drugs, and you can alter the way their kidneys are functioning, and essentially how much they go urinate, that sort of thing. Okay, this slide, you don't have to go through this slide. It just shows some different vasopressin analogs and vasopressin-like peptides that are out there. I just want you to know that the big classes at this point. Okay, in terms of diseases affecting the vasopressin system, I think I brought up on Wednesday, diabetes insipidus. Diabetes insipidus is where vasopressin secretion or the response to vasopressin is insufficient. Okay, and remember people with diabetes insipidus, among other things, are thirsty all the time, right? And they also need to urinate a lot. And by a lot, I forgot the exact numbers, but it's a lot, right? Okay, well, here's the exact number. Having just said that, okay, 30 liters of a day, so that's a lot. Okay, and again, they're usually excessively thirsty. So some of the causes of diabetes insipidus include central diabetes insipidus is when basically the brain cells that make vasopressin aren't making enough vasopressin or enough correctly configured vasopressin. Does anybody remember two brain areas where vasopressin gets made? Hypothalamic areas? Silence. The paraventricular nucleus, the hypothalamus, and the supraoptic nucleus. Okay. Okay. Then another cause of diabetes insipidus would be renal insensitivity to vasopressin, which is called nephrogenic diabetes insipidus, and that's usually caused if somebody's got a mutation of the V2 receptor. Because again, guys are gonna want to remember, at least until you take the test, V2 receptor activation it occurs mainly at the kidney and is involved in stimulating reabsorption of water. Okay, and then drug use, including lithium, can inhibit, again, the effects of AVP. And also there's what are called, it's kind of a nice word, vasopressinases. So if people have vasopressinases that are too active, these are enzymes that degrade vasopressin, and you can have too much activity there. Okay, in terms of treatments for diabetes insipidus, if somebody isn't making vasopressin properly, you can give them vasopressin analog. You can also give them amiloride, which is a drug we'll talk about several times in this course, but it's a potassium-sparing diuretic. It's used for nephrogenic diabetes insipidus. And among other things, it blocks the reuptake of sodium in the collecting duct. Thiazide diuretics, so when you're blocking the reuptake of sodium, back up here in the collecting ducts, essentially you're mainly reabsorbing water, so you're getting an increase in water there. So thiazide diuretics can paradoxically reduce polyuria and non-lithium, induce nephrogenic and DI, so big point of thiazide diuretics can affect diabetes insipidus. And also indomethacin, which is like an anti-inflammatory type of drug, has been tried for nephrogenic diabetes insipidus, and it's an NSAID, right, and it's a prostaglandin synthesis inhibitor. As you remember, prostaglandins can affect vasopressin secretion, right? Okay, there's also the other, including, along with diabetes insipidus, you need to be aware of syndrome of inappropriate secretion of ADH, interestingly named disorder. So people with this, they have symptoms, or typically they got hyponatremia, so not enough salt in the serum, and also hypoosmolality. Okay, so so vasopressin can be over-secreted in this condition. Okay, or just basically the vasopressin system isn't responding correctly to changes in osmolality, etc. And it mainly occurs when there's high fluid intake, along with somebody's taking some kind of drug that might influence vasopressin secretion. And some of the causes include malignancies, pulmonary disease, etc. So, you know, people can have their vasopressin secretion system and responsiveness not functioning properly. That's SIADH. And some of the drugs that can induce SIADH are listed here. I'm not going to go through the whole list, but there are many that can influence vasopressin release. Okay, this slide just summarizes the vasopressin actions, right? So vasopressin, which gets secreted in response to increased osmolality, right? So among other things, we'll go down the blue side here first. Vasopressin is going to get released. It's going to activate the V2 receptor. Where's that found? Kidneys. Where? The collecting duct of the kidneys, right? So down near the end of the tubule system. Okay, so you're going to get the rapid insertion of this aquaporin 2 on the membrane, and so that's going to the membrane on the urine side, right? But then the water is going to go through those pores and get put back into the blood. So you have that increased permeability, and then you get conservation of water that way. Also, you can get V1A receptor activation. When you think V1A receptor activation, you want to be thinking about the vasopressor action of vasopressin. You know, there's just a whole bunch of things that can happen with that. You can get activation of the sodium potassium 2-chloride symporter in the, where's that located, remember?
ASIN.
The leukopennin, right? So you get activation of that, so you get some sodium conservation. Then also you get, again, you get the vasopressor action, so you get contracting of vascular smooth muscle, and you can also get, they don't really want to go into this too much, but increased medullary osmolality. So, which I know sounds funky, but you're bringing up osmolality some to help with water conservation. So it's maybe not the most intuitive thing since vasopressin gets released in response to increased osmolality. But basically you get this combined effect that you're conserving water, right? Oops, and that's it with that lecture. I've forgotten I'd done that. So here you can, I put the slides up, right? The whole presentation up so you guys can walk yourself through that one. And